Hello, my name is Amy McMahon from BSR Physical Therapy. This journal club is titled Adhesive Capsulitis, a review of current clinical practice guidelines. Clinical practice guidelines are publications put out by the orthopedic section of the American Physical Therapy Association based on current best evidence for that topic. The purpose of clinical practice guidelines are to define conditions using the World Health Organization's terminology, identify interventions supported by best current evidence, identify appropriate outcome measures we should be using with certain conditions. It can provide a description to policyholders, information for payers and claim reviewers, and create a reference for orthopedic physical therapists. The clinical practice guideline being discussed in this journal club is shoulder pain and mobility deficits, adhesive capsulitis. It's published in the Journal of Orthopedic and Sports Physical Therapy in May of 2013. A little background on adhesive capsulitis. It's more prevalent in women than men, aged 40 to 65 years old, the previous episode in the contralateral upper extremity. Primary adhesive capsulitis occurs between 2 and 5% of the general population, and secondary is reported to occur anywhere between 4 and 48%. And that's mostly related to having diabetes or thyroid disease. Risk factors include elevated serum creatine levels, type 1 or 2 diabetes mellitus, Dupuytren disease, thyroid disease, prolonged immobilization, myocardial infarction, trauma, and autoimmune disease. Anatomically, adhesive capsulitis involves what is called the capsulo-ligamentous complex, consisting of the glenohumeral capsule, coracohumeral ligament, and glenohumeral ligaments. Adhesive capsulitis was always thought to be an inflammatory process. However, some now find evidence of capillary and nerve growth in the tissues, which could explain these patients' heightened pain response. So there's a debate of synovitis versus angiogenesis taking place when the condition is present. However, we do know that fibrosis and contracture is consistently observed in these patients with surgery. Adhesive capsulitis has a relatively predicted clinical course. It's characterized by a stage progression of pain and mobility deficits. It's considered to be a self-limiting process lasting about 12 to 18 months. However, after this time, the patient may still experience mild to moderate mobility deficits, although report minimal disability at this point. Patients with diabetes mellitus may have worse outcomes. There are 4 stages in the clinical course, which we will discuss. Stage 1 lasts usually about up to 3 months duration, is characterized by sharp pain at end ranges of motion, achy pain at rest, sleep disturbance. However, there's minimal to no range of motion restrictions at this point. Perhaps you'll find early loss of external rotation range of motion with an intact rotator cuff, which can sometimes be a hallmark sign as to the beginning stage of adhesive capsulitis. Under arthroscopic exam, you may find diffuse synovial reaction, but no adhesions or contracture yet. Stage 2, the painful or freezing stage, lasts between 3 and 9 months. There's usually gradual loss of motion in all directions due to pain. There's that synovitis versus angiogenesis seen with arthroscopic exam. Under anesthesia, there may be some loss of motion. Stage 3, the frozen stage, between 9 and 15 months, the patient will have pain and motion loss. That synovitis or angiogenesis reported to be seen decreases, but there's progressive capsulo-ligamentous fibrosis. And under anesthesia, you might see loss of axillary fold and range of motion. Stage 4, the thawing stage, the pain begins to resolve. Stiffness persists 15 to 24 months from initial onset, sometimes even under anesthesia still. And the capsulo-ligamentous complex fibrosis is still seen under arthroscopic exam. Diagnosis or classification of these patients. is largely determined by history and physical exam. A patient will typically present with gradual and progressive onset of pain, sleep disturbance, pain and ranges of motion, painful and restricted active and passive range of motion, and elevation and rotation for at least 1 month, which plateaus or worsens at this point. Functional activities that are difficult include reaching overhead, behind the back, out to the side, etc. Most characteristically, a patient will have global loss of active and passive shoulder range of motion loss of greater than 25% and at least 2 planes of motion, or passive external rotation range of motion loss that is greater than 50% of the uninvolved shoulder, or less than 30 degrees of external rotation on that side. These characteristics have typically been used to define adhesive capsulitis in multiple studies. That's how they determine their patients who have it to be included in the study. Typically, the capsular pattern described by Syriacs has been used to signify adhesive capsulitis. This is external rotation range of motion loss, which is greater than the loss of abduction, which is greater than the loss of internal rotation. This has not been consistently found across this patient population. Runquist et al. In 2003 found varying patterns. Most common was loss of external rotation with arm at side, followed by loss of abduction and internal rotation, which is consistent with the capsular pattern. However, there was also greater loss of internal rotation instead of external rotation, with the arm position as close as possible to 90 degrees of abduction. Syriacs has reported normal strength and painless response with isometric strength testing, but other studies report reduced isometric strength and pain, so there's inconsistencies there. Special tests like impingement tests aren't too helpful in differentiating between rotator cuff tendinopathy and adhesive capsulitis because in either situation they're going to provoke pain. Due to some varied findings of diagnosis and treatment of patients with adhesive capsulitis, it would be beneficial to have an impairment-based classification to guide rehab, direct intervention, and educate on prognosis. This is what we will now discuss. Clinical practice guidelines, the ones we're talking about, have proposed a model for diagnosis, examination, and treatment of patients with adhesive capsulitis. There are 4 components. The first one, medical screening, is simply to determine that patient's appropriateness for physical therapy versus consultation with another appropriate healthcare provider. The second component is differential evaluation of clinical findings. You want to place the patient into a diagnostic classification. The first one is shoulder pain mobility deficits, adhesive capsulitis, or that patient with shoulder pain might fit into shoulder stability and movement coordination impairments, which is consistent with dislocation of the shoulder joint or sprain and strain of the shoulder joint, or shoulder pain and muscle power deficits, consistent with patients who have rotator cuff syndromes. We will discuss further the first one, adhesive capsulitis. The clinical practice guidelines have determined that in order to rule a patient into this category, there are certain ways they will present. To rule them in, a patient should be between age 40 and 65, have gradual onset and progressive worsening of stiffness. They should report limited sleep, ability to groom, dress, and reach. Glenohumeral passive range of motion should be limited in multiple directions. External rotation should be the most limited, more particularly in adduction. Glenohumeral external rotation or internal rotation range of motion decreases as the humerus is abducted from 45 degrees toward 90. Passive motion into end ranges will reproduce the patient's shoulder pain. Joint glides should be restricted in all directions. There are certain criteria that would make you want to rule your patient out of this category. Those criteria would be: passive range of motion is normal. Radiographic evidence of arthritis is present in the shoulder. Passive external rotation or internal rotation range of motion increases as the humerus is abducted from 45 degrees toward 90 degrees. And the reported shoulder pain is reproduced with palpation of the subscapularis. This might make you think that the subscapularis is limiting external rotation in lower planes of motion. You'll also like to rule it out if upper limb nerve tension testing reproduces their reports of shoulder pain. You would also be suspicious if shoulder pain, the shoulder pain that they complain about, is reproduced when you palpate peripheral nerve entrapment sites. Once you rule a patient into this category of shoulder pain and mobility deficits, in order to treat them, you then want to determine their tissue irritability level. You would place them in the category of high irritability if they're reporting their pain to be 7 out of 10 or higher. Their pain is consistent at night or at rest. If they have high levels of disability on standardized outcome measures. If pain occurs before they even get to their end ranges of active or passive motion, and if their active range of motion is significantly less than their passive motion. They would be classified as having moderate irritability if pain is 4 to 6 out of 10. Night or resting pain is intermittent. They have moderate disability scores and outcome measures. Pain is now more towards end ranges of active or passive motion, and their active range of motion is similar to their passive range of motion. Low irritability would be 3 out of 10 or less pain, no night pain or resting pain, minimal disability and outcome measures, pain with just overpressure into end ranges of passive motion. Their active range of motion is the same as their passive range of motion. Intervention strategies will be based on which irritability level they are. Those with high irritability, we could use modalities: heat for pain, e-stim for pain. In self-care or home management, you want to educate the patient on positions of comfort and activity modification to limit tissue inflammation and pain. Manual therapy will consist of low-intensity joint mobilizations in pain-free ranges and positions. Mobility exercises should include pain-free passive range of motion exercises and pain-free active assisted range of motion exercises. Those with moderate irritability, you can still use heat and e-stim for pain. Patient education, you want to be educating them to progress their activities at home to gain more motion, but still teach them not to create tissue inflammation and provoke a lot of pain. Manual therapy, we can now use more moderate intensity joint mobilizations, progressing the amplitude and duration of the procedure into tissue resistance, but still without producing post-treatment tissue inflammation and pain. Stretching exercises can be utilized. You want them to be gentle to moderate, progressing the intensity and duration into tissue resistance, but without post-treatment pain. Neuromuscular re-education can be used. These procedures are to integrate gains in mobility into their normal scapular humeral rhythm movements while they perform reaching activities. Those with low irritability, modalities aren't as needed at this point. In terms of their home management, you want to educate them to progress to more high-demand functional or recreational activities. In manual therapy, we can now use joint mobilizations with higher amplitude and longer duration into tissue resistance. Stretching exercises, the same. You want to progress the duration into the tissue resistance. Still careful about post-treatment inflammation and pain. Neuromuscular re-education. These procedures are going to be integrated to create mobility into normal scapulohumeral movements during activities, not only just reaching, but during all their functional recreational activities. So when we do our examination with these patients, the outcome measures found to be appropriate for this patient population are the DASH, the ASDS, and SPADI. You want to report on their activity limitations, which are usually pain during sleep, grooming, and reaching. Physical impairment measures that you want to document are active and passive range of motion with a goniometer, either in supine or standing. You want to make sure you measure external rotation in both adduction and in abduction to 45 degrees or to 90 if they can get to 90. You also want to measure internal rotation in abduction to 45 or to 90, shoulder flexion and shoulder abduction. Should also note joint accessory motion or the translatory glide loss in each direction of the shoulder. Interventions based on the current best evidence is what we will discuss next. The first intervention, although not employed by physical therapists, but was found to have strong evidence behind it in this patient population, is cortisone injections. Intra-articular cortisone injections combined with shoulder mobility and stretching exercises were more effective in providing short-term pain relief and improved function compared to just shoulder mobility and stretching exercises alone. And through several studies, there's been strong evidence to support this. Patient education. There's moderate evidence to support educating patients on the natural course of the disease and what they can expect with their outcomes. It kind of decreases their fear of if they'll ever get better with this condition or not. Also educating them on modification and encouraging function within pain-free motion, and educating them to match the intensity of their stretching program to their irritability level. There's weak evidence to support modalities. However, it's found that prior to manual treatments or exercise, there's less guarding and resistance to these activities if you use, say, heat or ultrasound or e-stim first to reduce pain. Joint mobilization. There's actually weak evidence to support the use of joint mobs for adhesive capsulitis. They say it can be used to reduce pain and increase motion and function. However, most of the studies show that although there's possibly beneficial effects, it hasn't been found to be superior to any of the other treatments we've discussed. Translational manipulation. This should be utilized only once the patient fails to respond to conservative treatment. There's weak evidence to support how great it is with outcomes, though. Stretching exercises. Moderate evidence to support. Clinicians should instruct the patient stretching with the intensity determined by the tissue irritability level. No studies have specifically come up with, any duration or any specific stretches that are most beneficial. They vary from study to study. In summary, we should know that adhesive capsulitis has a clinical course of 4 stages. We should be aware of what stage the patient is in, educate them on the clinical course of the condition and what stage we find them to be in. Very, very important to identify their irritability level before you begin treatment, because you have to treat according to the irritability level with the stretches and joint mobilizations you're going to use with them. You should also not be afraid to consider corticosteroid injection as an adjunct to your treatment, as the evidence shows that the patient will have less disability and more pain relief if they get an injection in conjunction with the treatments you're going to be giving them. Don't be afraid to utilize modalities for pain, and only consider a manipulation under anesthesia if your conservative treatment fails. If you have any comments or would like to discuss anything here, please feel free to comment below. Thank you.